So the next 20 minutes, I was asked to give you an insight on advances in endoscopy in IBD relating to cancer in particular. So these are my conflict of interests. So the aim of this talk is to address the question, what can we do to avoid development of advanced cancer and long-standing colitis, and what is the role of advanced imaging for detecting early lesions and in defining the treatment strategy for IBD. We know that the cancer risk, particularly in ulcerative colitis, and I will mainly focus on this part of IBD in this talk, increases over time. This is an older British 30-year perspective data collection indicating that the incidence of neoplasia increases over time after 45 years up to 27.5%, and accordingly, the incidence of colorectal cancer can increase up to 10% after 40 years after the disease onset. And the role of surveillance in terms of prevention for colorectal cancer and mortality from colorectal cancer in these patients is indirectly indicated by epidemiological data showing that, unlike the fact that the incidence of cancer goes up or neoplasia goes up, that mortality goes down over the different decades. And this reflects that we can pick up these lesions at an earlier stage. This is also reflected in more recent data from long-term follow-up from the United Kingdom, looking at almost 1,400 UC patients, where you can clearly see that the tendency of and the incidence of colorectal cancer is going down as such. So not only mortality is decreasing, but also the incidence as such. So how can that be? What could be the strategies behind this to decrease cancer in UC? Well, first of all, there's the better treatment of the disease. And to what extent can advanced imaging for endoscopists help here in 2020? Well, we do have now more and more available medications that can really get us to mucosal healing. And why is this important? Well, due to these increased treatment options, we have a more complex long-term treatment approach, where we also talk about the treat-to-target strategy, where the target, in fact, is reaching mucosal healing, or the exit strategy. So we can now actually come, unlike what we had in the past, where we had to settle for some kind of maintenance and some kind of residual disease activity, we can come to complete mucosal healing through to all the therapeutic options we have. So the STRIDE already indicated a treat-to-target strategy where we want to get to an endoscopic Mayo or a UCS score of 0 or 1. And the exit strategy is where we're actually going to think about stopping patients that are in long-term remission, where we want to balance the risk of stopping therapy versus the risk of continuation of the therapy, because this is also about preventing cancer in these patients, and then balance the risk versus costs. This is a difficult endeavor, and this is why mucosal healing and the assessment of mucosal healing is so important. Traditionally, most people do this with the Mayo endoscopic subscore when they do endoscopy, where 0 is really a normal or inactive disease, as you can see here. And then mild disease is where you have slight erythema, a faded vascular pattern, mild friability, but the main thing is that you don't have any epithelial defects. And then once you have erosions and epithelial defects, or you have more friability, then we talk about a Mayo 2 score. And the Mayo 3 is when you have really frank ulcers and spontaneous bleeding. And this is something that is usually easily assessed. A couple of years ago, the UCS, or UC Index of Severity, was developed by Simon Travis. And that is a more larger scale, where you score separately the vascular score, the bleeding score, and the presence of erosions and ulcers. The main thing is that you can do this during endoscopy, and this is also about quality of reporting. So you can see a decreased vascular pattern and slight erosions here, like you can see here. So if you see an erosion, then you already know that you're dealing with a Mayo endoscopic score of 2. And then you can assess this with all kind of new imaging techniques, and I will come back to that in a later, where we can see a vascular obliteration, patchy obliteration, because it's not always present. We have some small intermucosal bleeding here, so that's a score 1 for the UCS. And then we have small erosions, which can actually be better appreciated if you switch on some virtual chromendoscopy. So this is a UCS score of 3 in this particular patient. So the working definitions of mucosal healing that can be clinically important for Mayo is defined as equal or less than 1. So this is very simple. So it's a PRO that's a clear definition. It's easily assessed during routine endoscopy. It's universally used and is associated with reduced risk of colectomy. But the problem is it's only 4 grades, and especially in the lower end, where mucosal healing is important, the inter-observer variability is considerable. The UCS is a little bit more quantitative, where you have more response to change and potentially less variability, but it's also more complex to assess in a day-to-day endoscopy practice. So why do we use these scores of less than 1 or equal to 1? This is based on all data here that patients on infliximab maintenance therapy have a long-term remission if they have a Mayo 0 or 1 at week 30. And this Mayo score 0-1 is also associated with a lower decreased risk of the risk of colectomy if patients have this assessed after a couple of weeks of treatment. However, there's now new evidence indicating that we should actually have a more stringent definition that as Mayo 0 and UCS. And in the STRIDE initiative, this has now been defined as real mucosal healing. As you can see here, the ones with Mayo 0 have a better outcome in terms of long-term remission than those who have a Mayo 1. And the major issue here is the inter-observer agreement. So if you look here for the Barron score at the high end of the disease, which is actually very easy to access, you can see that there is a high concordance between different observers. So in 76% of the patients, everything looked like a Barron 3. However, if you move to the lower end of the disease, which is comparable to Mayo 0 and 1, then the concordance is only 21%. And this is really a problem if we want to define, if we want to stop patients, their treatment, or if we have actually reached that target, which might be important for the long-term outcome of the patient. Also for studies, this is important because this interesting trial used for the first time centralized reading. And what actually happened in this trial, initially the intention to treat analysis did not show a statistically significant difference because the inclusion of patients was actually based on the score of the on-site reader. But then when central reviewers excluded 31 of the patients with less than 2 on a baseline Mayo endoscopic score, actually the study all of a sudden became significant. So not only for real-time clinical practice, but also for studies, this is important. So can we do better here with high-definition endoscopy and virtual? Well, we published last year the Picasso score, which can actually better define mucosal healing. And this is based on virtual chromodoscopy, first with iScan and now also with iScan OE. And the cutoff here is here for mucosal healing. I will just take you through it. So here we have the Mayo 3 score, where you can clearly see ulcerations. And also here with the Picasso score, we assess the mucosal pattern and the vascular pattern. This is a UCS 5. You can see totally obliterated vascular pattern and ulcers. And Picasso, we have Mayo score, the mucosal score more than 5 millimeters, ulcerations that are patchy, and intermucosal bleeding is present with crowded vessels. So this is actually what we do. So you score different mucosal architecture and vascular architecture, and you look at dilated vessels. And especially in this lower end, what was interesting in this study is that we had a good correlation with histological inflammation. And Picasso features with healing are continuous regular crypts, vessels that are roundish following crypt architecture without dilatation. So here you can see we have these round crypts with nicely aligned, round, non-dilated vessels in it. Or we can have crypts with non-visible, that are not visible when we see the scars, like here. This is also associated with healing. Or finally, we can have this continuous and or dilated elongated crypts, but as long as the vessels are not dilated, this is still a feature of healing. So here you can see the crypts are a little bit dilated, but the vessels are nowhere dilated and crowded. So this is still healing. On the contrary, we can also identify histological mild inflammation when we find microerosions and crowded dilated vessels. And exactly these microerosions are better accentuated with virtual chromodoscopy. So we switch here from the standard white light now to the virtual chromo, so you can already identify slight erythema here. And you can see these round dark spots that are actually dilated vessels surrounding the crypts. Now we go to iScan 1, where we have surface enhancement, and you can already see appearing here these white little dots that are actually microerosions. And then when we finally switch to the iScan, you can see these white dots become more apparent, and this vascular pattern also. So with this, we can accurately predict something that is related to histological inflammation. In the future, we will use more automatic calculation, and we've been working on this red density project where we actually quantify the red density in collaboration with Pentax. This was done. So this is a system that is not currently available, but it works actually with spectrography, where you actually measure the redness, and it is indicated immediately during endoscopy. And what we showed was a very nice correlation with the Roberts histological index, and also a nice response to therapy for this. And this is really the future where we'll be heading. So the next strategy to decrease cancer is proper surveillance techniques and high quality. And what can we do with advanced imaging here? Well, if we look at this data again, it looks a little bit contradictory that we actually have a small increase in cancers in the last decade. And this is actually due, I think, to better detection and better techniques, because what we find more are actually early cancers, Dukes A or B, and we find less interval cancers. So you can see that the interval cancers in the era of high definition and chromendoscopy went down. And chromendoscopy is like digging for gold. If you have to choose this road or that road, I think everybody will choose this road when you want to search for gold. And this is the same with chromendoscopy. We know that standard biopsy protocols actually do not work very well. The yield is very low, 0.2%, in contrast to 23% for directed endoscopies. And we've come a long way. In the time that Blackstone described these so-called dysplasia-associated lesion or masses or DALM lesions, this is the images they had to work with. They were very vague, and at least, I mean, it was already surprising they could find all these lesions. And now we've come to the era of chromendoscopy and high definition, where these lesions clearly stand out. We can delineate them and then also resect them, like, for instance, in this case with the long-standing Crohn's colitis. The most recent meta-analysis clearly shows that there is a benefit of chromendoscopy versus white light endoscopy in detecting lesions. And this is in particular true for the standard definition endoscopes. It's not longer true for the high definition scopes with virtual chromendoscopy. So the main advantage of this is really in the standard definition chromendoscopy. And this effect is actually maintained over time. So every time you do a chromendoscopy, you will pick up more lesions with targeted biopsies, as indicated by this nice study from Marion. Over time, you can see they did always back-to-back design, but they did white light, targeted white light, and chromendoscopy. You can see that the upper bar is always the biggest, and these are the targeted chromendoscopy biopsies showing neoplasia. And the guidelines are clear now. The good thing is that we risk stratify our patients according to the family history of the patient, the presence of PSC, whether there are strictures or there has been a history of dysplasia. So this is the high-risk group that we see every year. Then we have the intermediate risk group with extensive colitis, which is mild activity. And then you have the patients, the low-risk patients. Basically, these are the ones where you do the endoscopy, and if you did not know they have had ulcerative colitis before, you can see them back every 5 years. And chromendoscopy is now the standard. You need your best resolution endoscope for that. I still like the spray catheter, and you need a clean colon in the presence of quiescent colitis, and you need more time for this. So time is always the issue for detection. That was already indicated for the Barrett's and for the stomach, and it's also true, I think, for UC. We schedule usually 45 minutes for a patient like this. And then it works very well. So this is a patient with long-standing UC, and after methylene blue, you can see this nice UC-related neoplasia here, which you can nicely delineate. And then you can see this reddish spot here in the middle. And then we can apply the methylene blue, and you wait for 1 minute for it to be absorbed. And then you can nicely assess this aberrant pit pattern here on the top. You can see it turns a little bit pink, and this is actually a small cancer in a long-standing UC. And we can use the Kuda pit pattern in kind of a dichotomous way, where we use the round and star-shaped pits as a non-neoplastic and all the rest as a possible neoplastic, Just keep in mind it's not the same, so the yield here for neoplasia is still only about 30%, but still this is what helps you to target your biopsies. So what does it mean? If you see something like this, all these pseudopolyps, they have actually a perfect, nice type 1 pit pattern, and you don't need to biopsy this. This is just normal colon mucosa. In contrast, if you see something like this, and in conjunction with that, you can see a type 3L pit pattern. These are the ones that at least you want to take a biopsy out to exclude neoplasia. And then, do we really need chromendoscopy? Can we switch to all these nice new virtual chromendoscopy modalities that we have? We performed and published last year a randomized trial, NBI versus chromo, where 66 patients were randomized between chromendoscopy and narrowband imaging, so a total of more than 130 patients. And the bottom line here is that in terms of neoplasia detection, absolutely there were more lesions in the chromo group, but this was statistically not significant because there was one outlier with 9 cell-ulcerated lesions. But if we look at the neoplasia detection rate, this was exactly the same between the two groups, so there was no difference between chromo high definition and NBI high definition. But what was important is that the total procedure time on average was 7 minutes shorter with NBI, and the possible advantage I think lies here when you have a difficult colon or less well-prepared colon that you can still clean, and when you have to go back and forth and it's a difficult colon, you don't have to pass the same difficult passage twice. Also important is you can decrease the number of biopsies size per patient. The number of biopsy size was about 4 per patient, and in 1 out of 4 patients there wasn't even any need to take a biopsy at all. And after long-term follow-up, we didn't have any missed cancers in the patients that were in the trial so far. So it really works. Here's an example of a non-polypoid slightly elevated type 2A lesion that you can see here. You can also use, in this case it was FICE, where you can distinguish an inflammatory polyp with a normal pit pattern and a fibrin cap on top. So these are the ones we don't have to worry about. But what happens if we turn the scope now, and this is the same polyp, and then you have this flat lesion, which is already visible with high-definition white light. But when we switch on the virtual chromendoscopy, you can nicely delineate this UC-related neoplastic lesion, which contain low-grade dysplasia. So it really works in real life. You can detect small lesions. This was a patient with long-standing PSC. You can see this slightly elevated part here. Switch on the chromo, and then you can delineate the entire lesion that can be resected then, and you can also assess the pit pattern as a type 3, type 3L or 4 pit pattern. And even in difficult cases, we try to use everything, sometimes combinations with virtual chromendoscopy and real chromendoscopy, just like you do for Barrett's or for squamous cell cancer. So this is difficult and challenging to interrogate the entire mucosa, but it is feasible actually to see that there are sometimes polyps that have a totally different pit pattern than the normal pit pattern, and then you can actually find a needle in the haystack, like for instance here, this adenoma with low-grade dysplasia in this patient. So this has also been included now in the recent ESG guideline that was published, that will be published this month, where we recommend the routine use of dye-based pancolonic chromendoscopy or virtual chromendoscopy with targeted biopsies. Obviously, when it's a quiescent disease and adequate bowel preparation. We do indicate that you need to get proper training for this, and we are currently defining this in the ESG curriculum. And if you have done this, then you can abandon the non-targeted 4-quadrant biopsy. So we'll go a little bit further here than the scenic classification. And then ESG suggests that in high-risk patients, those where you feel uncomfortable, or the one that I showed you with the multiple pseudopolyps, maybe there you can still use the non-target biopsies. What about training? This is my personal view on this. I think you should start by using dye spray and have backup random biopsies for at least 20 cases. And then you can switch to dye spray with targeted biopsies only and get histological feedback and get some feedback on what you're seeing. And once you've done that, you can start using virtual chromendoscopy in combination with BI for about 20 to 50 cases. And I think then you can definitely move to permanent virtual chromendoscopy. But that's my personal opinion. So in conclusion, IBD colitis is associated with an increased risk of colorectal cancer development, and epidemiological data suggest the beneficial effect of surveillance, and advanced imaging in particular can help to assess better mucosal healing and to improve detection of early neoplasia, and hereby reduce the risk of mortality from colorectal cancer in these patients. Thank you for your attention.